Hello, everyone. Welcome to RxConnect. This is a podcast brought to you by the Pharmacy Operations Department at American Oncology Network. And I'm your host, Cassie Perkey. I'm one of the board certified oncology pharmacists here at AON. And RxConnect is a monthly podcast where we break down oncology pharmacy updates and share practical tips to help patients manage cancer treatment side effects at home. And in this episode, we are recognizing Breast Cancer Awareness Month by focusing on a side effect that doesn't always get as much attention as things like nausea or fatigue or hair loss, but can really be just as important, if not more important, to monitor. And that is cardiac side effects or heart side effects. So certain drugs often used in breast cancer, like doxorubicin or trastuzumab, can sometimes affect the heart. So we'll talk about how and why this happens and what's done to monitor the heart during treatment and what patients can be looking for at home. So today I'm joined by Dr. Whitman. She is a medical oncologist at Zangmeister Cancer Center in Columbus, Ohio. Dr. Whitman is a board certified physician in hematology, medical oncology, and internal medicine. And she treats all cancers and blood disorders, but she does take a very special interest in breast and gynecologic cancers like ovarian cancer and uterine cancer. And she is actively involved in clinical trials and emphasizes the importance of survivorship and quality of life in cancer care. So she's the perfect physician to have here as our guest for Breast Cancer Awareness Month. She's here to share her knowledge and experience with what patients should know about how to protect their heart during breast cancer treatment and how providers and pharmacists can work together to keep patients safe while on these really important therapies. So before we get started, just a quick disclaimer. This podcast is intended for educational purposes only. We may discuss medications that have off-label uses. This is not to be taken as medical advice because every patient's situation is different. So please always talk to your own provider and pharmacist before making any changes to your medications or your care plan. So, Dr. Whitman, thank you so much for being here. My first question I have for you is just what is cardiotoxicity and how can chemotherapy affect the heart?
Yes. All right. Well, thank you for having me. It's a pleasure to be here. So this is certainly something we are very cognizant of and closely watch, especially in our breast cancer patients, because of the drugs that we use. Cardiotoxicity just means basically injury to the heart, and ultimately that injury to the heart can affect the way the heart functions, and that's when we run into problems. So chemotherapy can cause damage to the heart in a number of different ways. It can be toxic to the cells that make up the tissue of the heart that affect how the heart pumps. It can also affect how the electrical current through the heart works. So there's multiple different ways in which chemotherapy can damage the heart, but ultimately, it the problem is when the heart just does not work as well and can't pump the blood as strong and effectively through the body. And that's ultimately what we mean when we say cardiotoxicity.
Yeah, so with cardiotoxicity, um, like you said, we know there's always a small risk for these cancer or these cardiac side effects with cancer treatment. But are some patients more at risk than others for heart problems during treatment? And like, what are some things that might make someone higher risk or make you want to do a little bit more close monitoring with a patient?
Yeah. So when we talk about cardiotoxicity in breast cancer care, there's two big class of drugs that we think about. One is anthracyclines, and the most common drug we use is called doxorubicin. That is a chemotherapy drug. It's an oldie but goodie. It's been around for a long time, and damage to the heart most likely happens 1 to 2 years after a patient has been treated with one of these drugs. Um, in some studies, so all these studies are really retroactively looking at these patients. Usually we saw that when we're closely monitoring them, like looking at their heart function with an ultrasound of the heart, about 7% of patients had a decline in their cardiac function. It's way more common for someone to be asymptomatic and we catch it because we're we're monitoring than for them to be symptomatic from it. Um, and then the other big drug that we think about with cardiac injury and breast cancer would be HER2-based drugs. Most common ones, trastuzumab and pertuzumab. Um, and the biggest trials looking at that, the risk for heart failure, so symptomatic cardiac injury, was about 2.5%. That's compared to about a 0.4% in the patients who did not receive that HER2 drug. So it did increase the risk. But again, I just want to emphasize the rate is really low with these HER2-based drugs. Another trial looked, and only 3% of the patients developed a decline in the heart function, but those patients were asymptomatic, meaning just because the heart function, the pump wasn't as good, they were not symptomatic from it. Only 0.5% of the patients had a symptomatic decline in their cardiac function when they were receiving the drug trastuzumab.
Oh, I was just gonna say, this is, as a patient that maybe is getting one of these drugs and you do notice, like, they have an asymptomatic, drop in their heart function, so they aren't having symptoms, but you saw it on the heart ultrasound. I feel like as a patient, I might wonder, like, "Okay, I'm asymptomatic now, but, like, what are the chances that I could start to have symptoms, years later?" Is that something
Yeah.
that you've ever seen or addressed?
Yeah. So, I mean, what's the prognosis moving forward? Well, most patients, if it's asymptomatic, it's just kind of like to summarize the whole podcast here. Most patients with an asymptomatic decline in their EF recover and are totally fine. Um, there are some studies looking at, you know, what is the risk of of a future major cardiac event after receiving these drugs. And they all consistently show that if you are asymptomatic, your risk is really low. Um, and that kind of goes back to when you asked me about the incidence and the risk, like with anthracyclines, the chemotherapy drug we talked about. If you got a certain dose is really important with doxorubicin. If you get a certain dose of it, you carry about a 5% risk of heart failure. And so that's really important for us as medical oncologists to know because we determine then this is the max dose you can get. We don't like to go above that dose because we know when we do, we significantly increase that risk of heart failure moving forward and into the future. But if we stay under that dose, then we know your risk of heart failure is less than 5%.
Yeah, that's really good to know, and that cumulative dose or that dose limit that Doctor Whitman is referring to, is something that, your doctor and your pharmacist, if you have a pharmacist that works with your oncologist, they are likely or they should be tracking that number in the background. You may not see that, but, they are keeping track of the cumulative dose of drugs like doxorubicin or daunorubicin, to make sure that if you're approaching that dose limit, that we're not going to go over and put you at even higher risk for heart failure. And I did want to just clarify one of the terms that Dr. Whitman used was EF, which she's talking about a measurement that we look at with like the ultrasound of the heart that she had mentioned, and it's ejection fraction or EF, and that's just one of the numbers that we look at to see how efficiently the heart is pumping. So I always just like to clarify or make sure we understand those kinds of definitions. But I was wondering, Dr. Whitman, what on that same note with the ultrasound, what other kind of monitoring is typically done before starting on drugs like doxorubicin or trastuzumab, and during these treatments?
Yeah. Yeah. Well, actually, stepping back a little before monitoring, a really important thing for your medical oncologist to do is really to look at your risk and are there other things. So we know you have breast cancer and this is what we should do for you, but we should also look at your overall health and your other health conditions. And do any of those conditions put you at increased risk in conjunction with these drugs to increase your risk of um, cardiac disease. And so you asked, are there other things that increase the risk? And yes, there certainly are. And HER2-based drugs, we know that age greater than 50, being overweight, having high blood pressure, and some studies showed that having diabetes all increase your risk of having heart-related disease from the trastuzumab. Another big one is sometimes in breast cancer care, we give both this chemotherapy drug, the anthracyclines, plus trastuzumab. We know when we give the HER2 drugs plus the anthracycline chemos together, we do increase the risk of heart disease. So actually, the breast oncology world has kind of moved away from giving both of them together. We do know safe doses that we can give at lower doses that are less risky. But for the most part, we do try to avoid giving those drugs together because of this risk. The same thing with doxorubicin, certain risks that we know increase the risk of cardiac disease, being overweight, diabetes, hypertension, age greater than 50. And really interestingly, there are some genetic findings they found that certain people are more sensitive to these drugs within their cardiac tissue. Now, it's not really standard of care for us to go checking for those genetic abnormalities, but it's something to keep in mind. And so, as a medical oncologist, knowing about these risk factors, and the ones I mentioned, a lot of them, high blood pressure, diabetes, obesity, those are just general risk factors for cardiac disease. So when we take your history and we understand your overall health, and then we look at the drugs that you need for your cancer, we have to start thinking, are you going to be higher risk for these cardiac events? There are some scores, some online calculators and things we can do. But, the big one that I look at as a medical oncologist is, does that person have a history of heart failure? And heart failure is just when your heart is not pumping, it cannot keep up. Um, that to me is a big red flag. Having already a baseline, if they have a history of major heart failure, well, then that would be a no, you can't have these drugs. But if you have very mild heart failure or other really complicated cardiac disease, that's when I really start thinking about, are there other ways to reduce risk? And of course, that's where we get into the monitoring and are there ways to prevent?
Yeah, absolutely. I didn't realize that there was even possibly a genetic component to that. So I wonder if, in the future, if that could be something that would become like standard of care in patients that are starting on these types of drugs, if that would be like a panel that might be run to see, if there's, extra monitoring that would be required or different considerations like that. Of course, none at this point, but certainly interesting for the future.
Oh,
Um,
yeah. Yeah.
yeah. So, what like you had mentioned with monitoring, what can patients expect for, monitoring as they are, because if they're on something like trastuzumab or pertuzumab, they're likely going to be on that for at least a year usually, depending on if the patient has early stage breast cancer or metastatic breast cancer, it could be longer. But with being on those for that amount of time, how often are patients getting scans or imaging for looking at cardiac side effects?
Yeah. So, with the trastuzumab HER2-based drugs, there's a very set schedule for how we should monitor. So we use an echocardiogram, which is an ultrasound of your heart, and it looks at how well your heart is pumping. It gets that EF measurement, which you explained for me. Um, so with HER2-based drugs, we found that the best monitoring is before you start treatment, because that's where I'm screening, does someone already have heart failure that we're not aware of? But then it gives us a baseline, because moving forward, we then repeat the echocardiogram at months 3, 6, 9, and 12. And 12 would be the completion of HER2-based treatment for anyone in the adjuvant setting, meaning you had surgery and now you're getting chemo for that stage 1, 2, or 3 breast cancer. Um, Echocardiograms are just an ultrasound, so they're not painful. There shouldn't be any radiation from it. And what we do when we look at these ultrasounds is we look at the measurement, the EF, and we have very strict guidelines for, has there been a change? How much did it change? And that's how we determine if things are safe to move forward or if we need to make adjustments. But for anthracyclines like doxorubicin, we again get the echocardiogram before you start treatment. But then there's not really a set standard of care for how you should monitor it moving forward. Um, there's been differing recommendations, but overall, we look at cumulative dose of doxorubicin. So, like Cassie said, those pharmacists are measuring how much doxorubicin you're getting over time. And once you've reached a certain dose of doxorubicin, I like to get another echocardiogram. And then once we start hitting up in the higher doses, no, this is for very select patients, then you start continuing to measure that echocardiogram, usually every 2 to 3 doses. Um, there's some interesting data too that looked at getting an echocardiogram 1 year after a patient has completed treatment with an anthracycline. And that can be another good way to screen for asymptomatic decline in cardiac function.
So, kind of as a follow-up to that question, if a patient, does have some change in their heart function that you see on the echocardiogram, uh, and you see that it has declined, whether the patient has or even if they don't have symptoms, does that mean that their therapy has to stop? And, like, what typically would happen with a patient's treatment regimen if they did show signs that they were having, some side effects?
Yeah. So how do we treat patients with it? Well, so there's this really strict protocol. So if a patient's asymptomatic, meaning there is no evidence of heart failure clinically, then we hold the drug. We hold the trastuzumab or the pertuzumab, and we hold it for 4 weeks, and we repeat the echocardiogram. And if we see improvement, if it gets back up to baseline, then we can generally re-challenge or restart the therapy. And again, there's a whole algorithm that you follow depending upon the response. So the majority of patients can be rechallenged. They can be retreated because again, most of these patients are asymptomatic, and we know the strong majority of trastuzumab patients with this recover. Uh, if However, if you're symptomatic with heart failure, so symptomatic heart failure, heart disease would be increasing shortness of breath, weight gain from fluid retention, uh, shortness of breath when laying flat, heart racing. Um, if a patient has any clinical symptoms and then any clinical signs. So when your doctor examines you, do they find any signs of heart failure when they listen to your heart sounds or do an exam? Well, then that would be a reason to say, no more. Let's stop the trastuzumab because you now have symptomatic heart failure. So generally, that's what happens in regards to treatment. Um, when a patient has symptomatic heart failure, I tend to get my cardiology colleagues involved because the treatment is the standard of care for any type of heart failure. So I'm really lucky here at where I work that we have a cardiology group that has a few doctors that are very interested in oncology cardiology. So I tend to send my patients to them to help me manage when patients are symptomatic. If they're asymptomatic and they don't have any other risk factors, I generally will just repeat the echo and see how patients do and wait to get cardiology involved and unless, things aren't improving.
It's always really nice to be able to have, those cardiology, colleagues close by or a phone call away. And that's not a resource that everybody has, but if you do, it's really valuable because we do just there are so many different, chemotherapy and immunotherapy drugs that have potential for heart side effects. I feel like, the list grows, of things that apply for the cardio oncology world, or where a cardiologist might have like extra training or special interest in oncology and like chemotherapy drugs.
Yeah,
Um,
yeah.
yeah, but I guess once a patient's treatment is completed, so let's say they've completed their, year of trastuzumab, they had early stage breast cancer, HER2 positive breast cancer, and they've completed their post-surgery, therapy, or they've completed, doxorubicin treatment, um, for, like, survivorship and years after. Do patients need to keep getting their heart checked over time? Is it something that, like, periodically they'd be checked in on? Or, is it more of something like if the patient starts to have symptoms arise, is it something that you would look at that time?
Yes. So I do like to do the echo 1 year post treatment for my doxorubicin patients because we know that the risk of it happening really is in that first 1 to 2 years after treatment. So I do like to do that in my patients. For my HER2 based patients, I do a completion echocardiogram at the 12 months. If someone is asymptomatic and no other additional risk factors for heart disease, I do not continue with echocardiograms. If I think someone has, risk for cardiac disease, at that point, I would defer to their primary care doctor or to cardiology, but I would really make sure that they had ongoing follow up to help manage those risk factors. But in regards to guidelines, there are no guidelines telling us to continue doing echoes once the patient has completed the HER2 based treatment.
Okay. Yeah, that makes a lot of sense. Um, and then just one last question for the podcast today. Wrapping things up, Dr. Whitman, for the patients listening, if they are, even whether they have breast cancer or any other type of cancer, and they know that they're going to be starting on a drug that can affect their heart, like doxorubicin, or a HER2 based therapy like trastuzumab, what's kind of like the biggest thing that you want them to know going into their treatment, regarding heart side effects? Like, what's, if they could remember one thing from our talk, what would be the golden ticket?
Honestly, I'd say just, keep up with your if you're on trastuzumab, keep up with getting the echoes. I know in visits, it's so overwhelming. You're getting all this blood work done, and there's all this other stuff happening, especially in the, treatment of early stage breast cancer. Those visits can really be packed full of stuff. And I find that a lot of my patients will forget to get their echo done, or they'll miss the phone call from the hospital to get it scheduled. And so I think I just would really emphasize, like, no, this is a really important part of your care, and it's really important to stay up to date on it. Um, and it's really helpful to your doctor to have that information in a timely manner. And then, the other thing I always emphasize is you can't really you have cancer and there's not a lot you can control in that regard, but you can really control, the risk factors moving forward, like for survivorship. And improving cardiac risk factors also improve your breast cancer risk factors. So we know that exercising, eating a heart healthy diet also reduce the risk of breast cancer recurrence. And so, yes, it's super important and all the toxicities that happen when you're being treated, but survivorship and how we approach those risk factors moving forward are also really important.
I really like that you mentioned those things, Dr. Whitman. I feel like, I mean, for a lot of our patients, getting these types of therapies, they do have g- usually often a good prognosis, and hopefully years of life ahead of them. So we really want to make sure that you're it's hard to look beyond the initial cancer diagnosis and the chemo and like the months ahead, but you also want to make sure that you're setting yourself up for success for the long term too. So that's a really good point to be thinking about, just like general like healthy habits and exercise and keeping up with the routine monitoring for your heart. So all really great advice, and that's all that we have time for today. But thank you so much again, Dr. Whitman, for sharing your knowledge on this topic for breast cancer awareness. And for those listening in, I really hope that this conversation helps you feel more informed and reassured about your heart health during breast cancer treatment. Cardiotoxicity is something that your care team is always watching for. It's not something that you have to carry the burden of worrying about all by yourself. That you have your provider and other your nurses and pharmacists looking out for you as well. So the goal is to, like with many things, catch any changes early when they're more manageable and adjust treatment if needed so that you can continue getting the best cancer care while we're also protecting your heart. So if you ever have new symptoms or questions, no matter how insignificant they may seem, bring them up to your oncologist or your pharmacist. You're not expected to figure out what's normal on your own. We're here to help you and support you through the whole process from your first infusion to your last follow-up. So thank you again for joining us today, Dr. Whitman, and sharing your expertise. We will be back next month with another topic to help support you during treatment. So if you found this helpful, we would love it if you shared this episode with a friend or a family member, and we'll talk to you next time.
The RxConnect podcast is produced by the pharmacy operations team here at American Oncology Network and music composed by the Synth Dude. Make sure to check out all our episodes of the podcast by liking and subscribing to our YouTube channel.